Welcome. Let's study together. Why? Well, it's easier and more fun. You'll be more efficient. Repetition is the key, and we'll be doing this a lot. And you'll get some free study notes. How are we going to do this? Well, we're going to have 5 questions per block. I don't want to make the blocks too long, so 15 to 20 minutes per each. There's no computer reading, so you'll be enjoying my pretty accent. There's no fancy formatting, simply because you're not going to have any on your exam, so make sure you get used to the white background. You're going to have 5 seconds per each question to pause, read, and answer, so make sure you do pause. And then we're going to talk about the correct and incorrect answers. Alright, at the end of each block, you're going to find study notes. They're awesome, so be ready for the screenshots. And guys, please, if you have more questions, make sure that you do pause them. Okay, I'll get to them, I promise. Okay, so let's see what we got here. So as soon as you see aggressive behavior toward others or animals, frequent physical altercations with others, use of weapon, intentional physical cruelty to other people or animals, property destruction, and younger than 13, think of conduct disorder. Okay, this is a must-know for your exam. So when it comes to treatment, we employ parent management training, anger replacement training, CBT, family therapy, education employment programs, social skills training. Well, unfortunately, the treatment is generally ineffective. Okay. When it comes to pharmacotherapy, we usually employ it for comorbid conditions. However, antipsychotics are not indicated. Okay, so since we're already discussing the correct answers, let's cover D and E as well. So 50% of CD children actually become adults with antisocial personality disorder, which in turn increases their risk for alcoholism and somatization disorder. So by saying that, we're going to exclude D and E as well, because they're true statements. Now let's get to the incorrect one. So ODD stands for oppositional defiant disorder, and this is definitely not the case of it, because it's characterized by the absence of destructive and physically aggressive behaviors. Okay, so this is a definite must know for exam. Let's go to question number 2. So we have a 3-month-old who's been fed honey, decreased muscle tone, lethargy, apathy. Think of colonization by Clostridium botulinum. So this is a case of infant botulism. So infant botulism results from intestinal colonization by Clostridium botulinum and affects infants between 1 week and 12 months of age. Most cases actually occur between 2 and 8 months of age. The initial presentation may involve constipation, shortly followed by weakness, feeding difficulties, descending or global hypotonia, drooling, anorexia, irritability, and weak cry. Now, there is a difference between the infant form of the disease and the adult form. So what happens in the infant form of botulism is that the organisms are ingested, usually with honey, and multiplied in the gut. and then they produce toxins. Well, what happens in the adult form is that we actually ingest food with preformed toxins. So obviously the correct answer is E. Now let's see. What do we have in choice A? So Werding-Hoffmann disease and other forms of spinal muscular atrophy tend to cause slowly progressive weakness over months, although sometimes symptoms may present at birth. So we can see that actually this child has previous normal visits. Likewise, we can exclude neglect. Because there's little impression to suggest this diagnosis. It's unlikely to have such a switch from a normal visit to neglected the following visit. Now, streptococcus, generally they do not produce toxins with primarily neurologic effects, so we can exclude that. And when it comes to thyroid disease, thyroid deficiency could present similarly, but the history should show a gradual onset and slowly progressive symptoms as opposed to this. Okay, so let's move on to question number 3. So what do we have here? Pay attention to this. If you skip all of this and just read the question, you're still going to be able to answer this correctly, because the question is so general that you basically don't even need the clinical scenario in this case. So sometimes you can save yourself some time and apply this trick. Okay, so again, we're being asked about the false statements. I don't like these negative questions that much, but hey, they help us learn. So let's see, what are the common side effects of using corticosteroids? They include skin thinning and purpura, cushingoid appearance, weight gain, abdominal striae, sleep disturbance, and mood changes. Hyperglycemia or new onset diabetes mellitus is more common in patients with pre-existing diabetes or at risk of diabetes otherwise. So it still can worsen the diabetes, and it changes the skin of the abdominal wall, as previously mentioned. Now, the development of cushingoid features, which is redistribution of body fat with truncal obesity, wasting of extremities, buffalo hump and moo face, and with weight gain, they're quite troubling to patients, and the risk of these complications is both dose and duration dependent. It can also increase supraclavicular fat pad size, hypertension, depression, mania, psychosis, and fatigue and weakness, primarily in the proximal muscles. Okay, now why do we find this statement incorrect? Well, high doses and or long-term use of corticosteroids have been actually associated with increased bone loss and osteoporotic fractures. So it definitely does not protect against these. Instead, it increases the risk for osteoporosis. Okay? Now let's go to question number 4. Okay, now we're going to discuss cystic fibrosis. One thing that we absolutely have to know about CF is that it's an autosomal recessive condition. That's a must know. So what do we have here? No, it's not an autosomal dominant. It's not an X-linked recessive. Exclude those two. Furthermore, After an affected child from 2 healthy adults, there's roughly a 25% chance that the next child would have CF. Okay, not 50%, 25. Let's exclude that one as well. The way we make the diagnosis is by elevated sodium or chloride in the sweat, not potassium. Sodium or chloride. And then if you want to confirm the diagnosis, we're going to do genetic studies. Now, why do we find this one true? Well, fertility is reduced in women with cystic fibrosis, and roughly 50% are fertile. Note that men with CF, actually 98% of them are infertile. So the pregnancy can be dangerous for maternal health, but many women with CF actually have delivered healthy offspring. Now, the infants, therefore, would be expected to be healthy, although all offspring would be carriers for cystic fibrosis, unless the father is a carrier for the disease. But that's not the case. Okay? Up to question number 5. So let's continue on the same topic and let's go one by one. We want to figure out the false statement. So, is this true? Yes, it is. Average life expectancy is around 30 years. Now, is this true? Yes, it is, because meconium ileus in a newborn or rectal prolapse in an infant should make you suspect cystic fibrosis until proven otherwise. That has to be remembered. Now, is this true? It's not, because the most common pathogens in CF are Staph aureus and Pseudomonas aeruginosa, not Klebsiella. Okay, is this true? Yes, it is, because roughly 85% of patients with CF eventually develop exocrine pancreatic insufficiency. Other complications of cystic fibrosis may include diabetes, cor pulmonale, portal hypertension, bowel obstruction. Okay, and we have already covered this one. It's an autosomal recessive disorder. And voila, that would be it. Let's sum it up. Get ready for the screenshots. Good job, guys. Thank you for studying together. Let's go on to the next block.